I always enjoy coming to this meeting, and I wanted to really commend people like Deanna and Heather who have been strong advocates for this rare but very important condition. So thank you for inviting me. It's an honor to be here today and meeting people like Jill, who I see once a year. It seems like it's regular now, and other members that are here today. I'm gonna shift a little bit. Diabetes is very common. Acromegaly is not, and they often coexist. These are just some of my disclosures. So I'm gonna speak about the relationship between diabetes and acromegaly. How common is it? How often do they coexist? And it's different than the usual diabetes when you have acromegaly and diabetes. And when to suspect acromegaly if you have diabetes. So diabetes in general affects about 10% of the population in Canada. And we can't screen everyone for acromegaly because it wouldn't be cost effective. And we'd be getting a lot of false positives, which would lead to the cascade effect of doing all these other tests and drive us all nuts and crazy, right? We'll talk about the prognosis with the combination and some of the treatments, which have already been covered, but I'll become more specific in terms of what's relevant to the combination. And the good news, there's always good news with any condition, right? In medicine, that we can decrease a lot of these complications. So I've already mentioned diabetes in general is about 10%. Most of it's type 2. A small amount is type 1, and there's other gestational and other secondary causes, in particular acromegaly. It's more common in certain ethnic groups such as South Asians and Hispanics and in the indigenous population. So I've already mentioned 90% of diabetes is type 2, and then the others are less than 5%. And under others is acromegaly. And even Cushing's can also be associated with diabetes mellitus, which can be due to insulin resistance. And there's a whole bunch of other ones. Now, in acromegaly, it's interesting because not only can acromegaly be associated with diabetes, but some of the medications we can use also. In particular, paclitaxel, which is the second generation SSA, and also in some cases, octreotide, or lanreotide, which is the first generation somatostatin analog. So this is just a registry. As you can see here, about a third of patients with acromegaly have diabetes. So it's not uncommon to have diabetes with acromegaly. It's actually quite common. And along with all these other metabolic risk factors such as hypertension and sleep apnea, etc. So how is it different? How is diabetes different in acromegaly? A lot of diabetes is because of a combination of a lack of insulin, even in type 2, or insulin resistance. The biggest factor in acromegaly is there's a lot more insulin resistance. Now, when we see insulin resistance in most patients with diabetes, they often have an increased body mass index, or they're overweight or obese by the criteria of definition. But here in acromegaly, a lot of people with acromegaly, a lot of our patients with acromegaly are often not that obese. They're not that overweight. So it's different. Despite that, there's a lot of insulin resistance that can lead to hyperglycemia, which is elevated blood glucose. And it gets complicated, right? I'm not going to go into all the science and the physiology, but the bottom line is there's a lot more insulin resistance because of the growth hormone excess itself. So how else is diabetes different than acromegaly? It's a secondary form of diabetes. So it's not type 2, it's not type 1. Although you could have type 2 and type 1, and if you get acromegaly, it can be worsened because of the secondary cause also. And again, I've mentioned that is because of the growth hormone and insulin resistance. And with time, also your pancreas will not work as effectively, leading to further worsening of the glucose control. The treatments are generally the same. So if you have someone with poorly controlled diabetes mellitus and acromegaly, you're still going to consider things like insulin and the newer drugs, or they're not that new anymore, with drugs like Ozempic and metformin, etc., or SGLT2 inhibitors. But we have to also consider to treat the acromegaly itself, whether it's surgical. I'm not going to go into detail because that was already mentioned by Dr. Langlois. The medical therapies, and perhaps at times radiation therapy. The good news is if you control your acromegaly, often the diabetes gets better too. But you still may need the non-specific diabetes therapies also. So you need a combination. Now, there's certain drugs that don't have an impact on glucose control, such as pegvisomant, which is a growth hormone receptor antagonist. But I've already mentioned drugs like paclitaxel and octreotide may actually worsen glucose control. Whereas pegvisomant, which is the growth hormone receptor antagonist, and Acromegaly won't usually have an impact on glucose control. So when we see a patient, it's always about personalized medicine. One therapy does not fit all. We have to look at the patient in front of us, talk to our patients, and see what's the right therapy for that patient in front of us. So it has to be individualized. So it's not like a cookbook. Every patient is special and different, and we have to treat them very, very accordingly with that specific characteristic profile sitting in front of us. And the good news is that we can prevent complications, but at the same time, when you have the mixture or the combination of someone with diabetes and acromegaly, especially if they're uncontrolled, the prognosis is often worse. But again, with treatment, the prognosis often improves. And it's not only because of acromegaly itself, but diabetes in itself can have associated complications such as kidney disease, eye disease, nerve damage, and heart disease, etc. So again, lots of complications with diabetes, regardless of acromegaly or not. But the biggest thing we worry about in the long term is cardiovascular disease with hypertension and heart disease, whether it's a stroke or a heart attack or coronary disease or even blockage in the legs or peripheral arterial disease. So this is just a slide showing prognosis in acromegaly. And as you can see, as if you have both diabetes and acromegaly, the prognosis is not as favorable. But this is often without therapy. If you have therapy, we can actually decrease or improve prognosis. We need to do a better job. We really need to do a better job as specialists, doctors, in terms of treating acromegaly, but not only acromegaly, but the associated comorbidities. What happens often is we're so focused just on acromegaly or the Cushing's, we forget about all these other things like sleep apnea, hypertension, etc. So it has to really be a multidisciplinary approach when we see someone with acromegaly, to look at everything and take our time with our patients and listen to them and look at their cholesterol. Do they have sleep apnea? Are they getting their screening for their colon cancer? Are we examining their thyroid? Are they getting their mammograms? So it's just not about just the one thing. It's just not just about growth hormone excess. So we need to look at everything. And this study showed that we're not doing the best job that we should be doing for our patients with acromegaly. So we have a lot to learn. So as I mentioned earlier on, we can't screen everyone with diabetes and acromegaly because it would be cost ineffective and it would lead to a lot of cascading effect. But there are certain populations that we should be screening. Before I go on further, I'm not sure about Quebec or other provinces or the US, but in Canada, in Ontario at least, if you go to an outside lab, outside of the hospital, the patients have to pay for their IGF-1 level. It can be anywhere from $75 to $100. Many of our patients can't afford that, unfortunately. It's not OHIP covered. So I think one thing we have to do with Deanna and Heather is we need to advocate to the government, at least to our ministries, that if an endocrinologist or a neurosurgeon orders this test, or if a family doctor orders this test with a specific note, what we're looking for, and there's pre-test high characteristics, it should be covered. That's a major impediment, the coverage of IGF. So often, I have patients in Niagara Falls, I have patients in Grimsby, and they can't come all the way to Hamilton before their appointment and go back again and come see me again because gas is expensive. Parking is expensive in a hospital. It's $20, $30 to park in a hospital, right? So if you add that to the cost of the IGF, it's a lot of money. So I think the government has to really look into this and cover this test because we do a lot of other things which are probably not indicated, but it's covered. So again, I think if the right person is ordering it, we need to make sure that this test is covered. So when do we suspect? If someone has all the features of acromegaly, the face features, the hand features, etc., we should be screening. So not everyone with diabetes, but if someone has diabetes and these things, we should advocate for screening, absolutely. If they have several associated other conditions, and this is a clinical acumen decision, right? So if someone has diabetes and sleep apnea and hypertension and dyslipidemia, and they look and there's a features of acromegaly, then they should probably be screened. Again, this is a clinical decision, right? So it all depends on your pre-test probability of having this condition. In someone who's lean with diabetes and they have features, but they have no other reasons to have diabetes, they should probably be screened. And someone who's poorly controlled or had worsening control of their diabetes, have a low threshold to screen. Not everyone, but just have a lower threshold. Keep it in the back of your mind to screen. And there's not much evidence on this last one. So if someone has a small lesion and they don't have features of acromegaly, I probably wouldn't screen. But again, without much evidence, there are recommendations to say that someone that was found to have a large tumor on MRI scanning in the pituitary, they probably should be screened. Again, the evidence is not that great, but I have a low threshold for doing an IGF-1 level on someone with a large pituitary mass. So what do you check when you suspect acromegaly? I'm not going to go into this because it was just covered recently. The best screening test and the best diagnostic test is an IGF-1 level, which is unequivocally high in a growth hormone. If the diagnosis is confirmed, then you'll go on to do an MRI because you don't want to do it the other way around. Because if you take 100 people in Canada, about 10% of us have pituitary tumors. It's very high. And these are called incidentalomas, which has no clinical significance. It's just going to drive you nuts, and we don't want that. So we always say only do imaging after you've had a clinical suspicion and a biochemical confirmation of disease, whether it's adrenal disease or thyroid disease or pituitary disease, etc. And then again, if you have diabetes and acromegaly, then we have to do the other comorbidity type screening or the complication screening. So if you want to look for diabetes, you're going to do the A1C to monitor for diabetes control, a foot exam, eye exam, etc. All these other things you're going to do in terms of diabetes investigations. So the goals of care, if you have acromegaly and diabetes, I just have one suggestion, Deanna. I think it's hard to see that screen from that side. Am I correct? Is it a little bit difficult? Maybe if we can, during the break time, if somehow they can move the screen a little bit closer, if it's possible. It is a little bit challenging to see from there. So it's just not me, right? Okay. So again, to summarize, it's just not about treatment of acromegaly. It's about treatment of acromegaly. It's about the treatment of the diabetes, and also looking at the cardiovascular and the cardiometabolic complications and screening for those things. So it's a whole multidisciplinary approach to looking at how to best optimize investigations and therapy for your patients for both diabetes and acromegaly. So it needs time. It needs time. So what about some of the ABCs? What can you do? What's the good news? So now we have really cool ways of monitoring glucose control. We always thought just about A1C. Who's heard about the sensor, continuous glucose monitoring, CGM, Libre, Flash? So this gives us a lot of feedback on your eating patterns, on your dietary patterns. And we're going beyond A1C because this will give you instant feedback on what should we be doing to improve our glucose control. At the same time, looking at your acromegaly there. So this is really important. And we know that the tighter we can get our A1C or time in target, we can improve, hopefully, complications, especially kidneys, eyes, and nerves. And of course, treat acromegaly specifically also. Blood pressure is very important too. So now it's really simple. The new guidelines say for everyone at high risk, the blood pressure target at home or in the office, at least at home, should be less than 130/80. So really easy. And this is in particular to prevent kidney disease and stroke. Really, really important. And again, I always put, and also controlled acromegaly specifically. But even if you have your acromegaly controlled, your blood pressure still may be high, and you may need specific blood pressure therapies, safe, effective therapy, because blood pressure is very common, even outside of acromegaly. Probably one of the most important things to decrease your overall heart risk, and your stroke risk, and your cancer risk, and your lung risk is smoking cessation. Difficult, right? It is difficult, I know. But there's a lot of support available, whether it's network support, healthcare support, website support, and there's good therapies now also. So again, easy for me to say, but it's critical to try to maintain the least amount of cigarettes possible to improve your overall health, and you save a lot of money, right? You save a lot of money. Cigarettes are expensive. I still think they are expensive. Diet has to be culturally friendly. I can't tell someone who's South Asian to stop eating samosas. Very difficult, right? Or stop eating roti. Or someone who's of Southeast Asian community stop eating rice. But there's ways. There's rice that has a lower glycemic index. There's samosas where you can use an air fryer rather than deep fried. So we can make a lot of modifications these days to improve our diet. And we all probably need to eat less. Outside of these meetings, we can eat a lot here, but generally speaking, right? So exercise has to be fun. We can't tell people to join a gym. It's got to be fun, specific, and sustainable, and prescriptive. Okay, and it has to be a family event. So as long as you can do it on a regular basis, whatever you like doing, do it. Right? You don't have to spend a lot of money. Walking is probably the most effective thing, as long as it's somewhat brisk, as long as you're fit to do that. F. You want to keep your cholesterol under control, especially the LDL, which is the bad cholesterol. For most people with diabetes, you want it to be less than 2 in the Canadian units, which is 80 in American, a milligram per deciliter, I think. And if your risk is even higher, you want it less than 1.8 millimole per liter. And this can all reduce stroke and heart disease. And of course, controlling your acromegaly will also lower cholesterol also. So this is all the really good news. So even better, if we do control acromegaly, your IGF, in your diabetes, on the bottom right, which I put in green, we can decrease many, many complications, whether it's your diabetes, your glucose control, sleep apnea, hypertension, etc. So lots of good news, right? What's the bottom line? A lot of good news. I always like to end off with good news. Diabetes is common in acromegaly, up to 30% or more, and it's different than the garden variety of diabetes. So there's more insulin resistance, And should we be screening everyone? Not everyone, but a lot more than we have been, especially if there's typical features, if they're thin without any associated features, and it's progressive and hard to control. Prognosis is often not as good as someone who doesn't have diabetes if you have acromegaly, but the good news is there's lots of good treatments for acromegaly, as was discussed earlier, and for diabetes in general anyways. We have all these amazing new drugs, such as Ozempic, which is safe for the most part, despite what you read in the newspapers, if it's selected in the right patient, right? It's not for everyone. And SGLT2 inhibitors, and there's lots of new stuff coming out also. And again, good news is good control of your acromegaly and diabetes can reduce all these complications. So not only do you want a longer life, which is always not as important, but a better quality of life. A couple of quotes I wanted to leave with is, education is the most powerful weapon which you can use to change the world. And that's why we're all here, right? That was by Mr. Mandela, who was one of the people that I actually have a lot of respect for. And an investment in knowledge pays the best interest, Benjamin Franklin. I have a couple of questions just to make this somewhat interactive because this is adult learning. The first question is, when should you suspect acromegaly in someone with diabetes mellitus? There's only one right answer. So there's 4 possible answers, 1, 2, 3, and 4. What's the right answer? So number 2 is kind of silly, right? Okay. Yeah. Number 1 is absolutely the right answer. Yeah. Second question and the last question is, which statement below is false? 1, 2, 3, or 4? What's false? Yeah, so you guys are all really, really smart. 3 is the right answer. So good control does improve complications. Thank you very much.
Thank you, Dr. Prebtani. And I know I'm probably saying that wrong.
That's okay.
Anybody have any questions?
Thanks, Doctor. Great presentation. Recently, in the U.S., there's been studies and presented to Endo where it shows that about 25% of people with diabetes have high cortisol. And I'm wondering if there's any study or any idea that it should be looked at in acromegaly as well, where people with type 2 diabetes are being screened more often.
Yeah, so
because they thought it was 5%. Sorry, before this
it's
study.
Probably higher because of the insulin resistance. So many patients with acromegaly and diabetes, the garden variety diabetes, have high cholesterol, in particular high triglycerides, because of the insulin resistance. So it is pretty high, right? And we target based on risk. There's calculators that we use. There's the Framingham. Now there's the Prevent calculator, which can be online, and that allows us to predict the risk of cardiovascular disease and whether these patients need specific therapy in addition to their acromegaly therapy. And the most common therapy that we use to reduce LDL, which is the biggest bang for the buck, are the statin type of drugs like rosuvastatin or atorvastatin. Those are the 2 most common statins that are being used, high potency. And if their triglycerides are high, it depends on how high they are, because if they're really, really high, the risk is, if they're above 10 Canadian units, millimole per liter, the risk is for pancreatitis. Then we want to reduce the risk of pancreatitis by using specific strong triglyceride-lowering therapies, such as fibrates, for example. But if they're moderately elevated, then we're going to focus more on their cardiovascular risk. And again, the LDL will be taken into account to consider a statin therapy to reduce their LDL, at least less than 2, if not less than 1.8 millimole per liter. Vivian has a question.
Okay, you had 2 terms up there I'd like to ask about. You said diabetes test, foot exam. What does this mean?
So I guess it's not really a test. It's under physical examination. So in diabetes, if it's poorly controlled, you can get nerve damage. So you can get loss of sensation. The number 1 cause of amputations in Canada is because of poorly controlled diabetes, because you lose nerve damage. So you have nerve damage. So when you walk, when you step on a nail, for example, or step on a hard stone, you can get an ulcer, and that can develop into a foot infection or a foot ulcer. And the worst case scenario is osteomyelitis, which is an infection of the bone, and not often, but that can lead to gangrene. So foot exam is very important. A good foot care, and you need to be examined for your feet, how they look, And also we use something called the 10-gram monofilament to see how your sensation is. So that's the foot exam, a diabetes foot exam. It's part of, so anyone with diabetes should be having their feet looked at by their healthcare provider. And we often teach patients too. I always give my patients a handout how to take care of your feet. Make sure they always never walk barefooted, making sure there's no callus formation, and if it's really, really bad, to see either a podiatrist or some kind of foot care specialist or a chiropodist.
The second was the term you had up there was especially hip. Why hips?
Yeah, so hip, I think I was talking about arthritis, right? Osteoarthritis, yeah. So most people with arthritis, it often affects their knees and their hands, but for some reason, in poorly controlled IGF-1 levels, the hip is quite selectively affected. Some of the worst arthritis that I've seen is in the hip in patients with poorly controlled acromegaly after I take them over often. So hip is an interesting area. So if I see someone with hip arthritis, my differential diagnosis of the cause of hip arthritis changes, right? So if it's not acromegaly, I think of significant trauma, where they're playing a sport or something. But it's unusual to see really, really bad hip OA in most people unless there's some rare cause going on, either a traumatic sport or acromegaly. Often it's hip and knee, and often it's knee or the hands, etc. That's in the literature. And anecdotally speaking, I always, if someone has hip OA, I always think of acromegaly. And yeah, although still probably most commonly it's due to degenerative disease, but in someone who's young, who has hip-osteoarthritis, I'm always thinking of secondary causes. You shouldn't see hip OA in young people, generally speaking. So personal experience, right? Yeah. Yeah. I've had several cases like that also. Yeah, unfortunately. So again, that's where earlier detection and awareness. The problem with acromegaly is, doing this for a while is I think there's lack of awareness. Number one, lack of awareness. Number two, paying for that test. Number three, it's not primary care fault. The primary care sees you regularly, so they don't notice these subtle changes. Where when I'm walking on the street, if I see someone, often the diagnosis can be made right there and then. So it's the delta. It's such a gradual onset of a condition. The journey is so slow. And we can't blame the family. We can't blame the primary care, but it's lack of awareness. And I think that's where, if screening is covered in the right patient and photo recognition really comes into play with the research, that's going to make a big difference. The biggest thing family members tell me after the diagnosis is made, and this is not, I'm not saying it, is my partner is just not as handsome as before. That's what I hear, right? This is not in the literature, but that's what patients tell me. So, and the reason is because it's not recognized. It's not recognized. It's morphological, right? But I think if we can catch this condition earlier, we'll have an impact. I just wanted to make a point about if someone has a mildly elevated IGF-1 level or oral glucose tolerance test, which suppresses where you can maybe still have mild acromegaly. The important thing there is probably we don't have outcomes at that time. If we intervene at that time, we're going to have improvement in outcomes. But the important thing is not to discharge these patients. We still need ongoing follow-up because they might present themselves at some time to really have the disease or maybe not. But when a test is abnormal and your suspicion is plus or minus, we still need to follow these patients along. We need to be advocates, but we need to follow them along and just not brush patients off. Oh, your test is normal, see you later. So I think that's important to do, something to realize.
So I'm going to throw a side question here at you. My belief is, it starts out slow and your pituitary gland's creating hormone. It's going through your blood system, your liver, back up, picking up more, keep going around, back up, picking up more. But it's like it hits that certain point where it's got, quite a bit of growth hormone. And then it's still going where we're producing and picking up more. And it's like we've had it for already 5 or 6 years, but it's all of a sudden, boom, it's so high that I feel that's when the tumor just takes right off and grows really fast and we get hit really hard with all the signs and symptoms and we get diagnosed. That is what I believe, how it, gets to that point, right? Because we're constantly collecting growth hormone, not being dispersed out of our body. And it's like almost like that little tumor is like, oh, hey, I got so much growth hormone. Let's blast her out and become huge, right? You feel that that's how it goes from such a little baby tumor to a massive.
I based on the science that we have, most of these tumors are still very slow growing, so it doesn't often happen suddenly. What happens suddenly is all of a sudden the diagnosis is made, and it's in hindsight that often makes it feel that it's often sudden. But generally speaking, the tumor is quite insidious. Now, what can happen suddenly, and in hindsight, is that you get a complication, whether you get a hip fracture, for example, you get a heart attack or a stroke because of that acromegaly that hasn't been diagnosed. It's that acute complication. But it's not actual all of a sudden one day your hands grow big. That's been going on for a long time, right? And the tumor often doesn't grow very, very quickly. But what can happen sometimes is the tumor can grow in acromegaly if there's something called apoplexy, where it bleeds into the tumor, where the tumor hasn't actually gotten big, but it actually bleeds into the tumor. In fact, that's much less common in acromegaly than in non-functioning pituitary tumors. But it could happen. But generally speaking, it's that acute complication that, wow, all of a sudden. So it's not actually the tumor that's growing very, very rapidly. Where the diabetes becomes out of control because you have an infection. And that makes your glucose levels go very high at the time of an infection, for example, or a heart attack, or you get put on steroids for whatever reason, and all of a sudden your sugars go skyrocket, right? So that might make it appear that it's quite abrupt, but it's not actual tumor that's abrupt. Unlike Cushing's, is a condition where it's often much more progressive faster in most cases compared to acromegaly, which is more indolent. But that's still the problem, that we need to catch it earlier so we can prevent some of these long-term complications.
Any other questions?
Yeah, nice seeing you. And you brought up samosas and all that stuff. What's the prevalence around the world for acromegaly? Like, is there a cultural bias, or is the Western world are higher prevalence rates because we screen for it more?
Yeah,
or is
that was
it?
going to be my answer. That many of these countries, like I spend a lot of time in Uganda, and I hear from my colleagues, "Oh, I got a case of acromegaly," but we don't know. We don't know because often it's a clinical diagnosis. You can't do an IGF-1 level. For example, in certain places in Africa, in sub-Saharan Africa, if you draw an IGF-1 level, it's sent to South Africa. By the time it gets sent to South Africa, the test is degraded, so they can't even analyze it. Even things like aldosterone levels, or insulin levels, by the time they get to Dubai or they get to Johannesburg or Cape Town, they're cooked. So yeah, it's we don't know the prevalence. It probably is similar. Probably is similar, but I don't know the answer to that because of the lack of screening and investigations. India, we have some good data. It's probably similar because they can get all these tests done, but most of these low-income countries, LICs, we just don't know. But probably similar in Western Europe and in Canada, United States, and places that are HIC, high-income countries. One other thing I want to mention, thanks for reminding me, is the quality of life and the neuropsychological consequences are also very, very important to look at in acromegaly. We can't overlook these because these are critical. If you can't help someone's mental health well-being, we're really missing the boat.
Thank you.
Thank you very much.